Professor Guinea,
Good
please.
morning. Good morning and good afternoon, and to all the participants throughout the world. I'm very happy to and very honored to commence this EVRS webinar, which was very kindly organized by Professor Kakan from Pakistan, who was able to really get a wonderful team together of world experts on diabetes. Just a short introduction to the European Vitreoretinal Society, which I believe everybody is familiar with. But just to give a brief history, um, 20 more years ago, vitreoretinal surgery was coming out of its infancy. Uh, it started becoming something which was accepted by the medical profession and ophthalmologists in particular as a technique that could solve problems, and it was just not an experimental last ditch resource. So the few brave hearts that had been doing vitreoretinal surgery and really setting down the rules and the procedures that would allow this subspecialty to progress and to get to the point it is today, decided that it was about time to spread this knowledge among all ophthalmologists, those that were going to do the procedures themselves and those that would refer patients and had to know the indications for this to be done. So at the moment, at that time, there weren't many resources for knowledge to be spread. And that's how the European Vitreoretinal Society came to be. Essentially, it was decided that because everyone and all the members could really contribute with their experience to the growth of the specialty, we would not have uh, a sort of um, um, horizontal teaching rather than a vertical teaching. So, from someone that could give us the knowledge to the rest, but it would be spread among the members. So, it was a very democratic approach to knowledge, I would say. And apart from organizing meetings and setting up a website which had for the first time I think in history a very complete video library where all the members could contribute with their videos and their experiences. We also created what was a school, so the European Vitreoretinal Training School in Bremen, which actually trained more than 5,000 surgeons so far. So this is more or less the history of the European Vitreoretinal Society. And I'm honored to say that many of the panelists today are members or have attended our meetings and have contributed greatly to the growth of the society and to the knowledge of vitreoretinal surgeon in their own countries and throughout the world. So um, thank you for being here, and thank you for all the people that are attending today. I know it's a Saturday. In many countries, it's a holiday. In some, it's not. Uh, the time zones are very different. So some people are still in the middle of the night. Others have gotten up very early. And I know that we have many attendees. I think, Professor Kakan, did you say more than 300 registrations so far?
It's 389 till 1
Yes.
till 8 a.m. GMT today.
So that is an impressive number, I think, and the number is justified by the fact that this is a very interesting topic because diabetes is on the rise throughout the world, both in the so-called um, um, developed countries as well in the so-called developing countries. We have seen that diabetic retinopathy is also on the rise, despite many initiatives of the national health systems to contain the damages of diabetic retinopathy. Many of these patients will end up in the operating room. And so knowing what to do and when to do it is essential. I think this is the reason why there are so many people interested. Professor Kakan, please take over.
So thank you, Professor Ginny. I will just briefly introduce the speakers of our session and title of our webinar. Our webinar is about the management of advanced diabetic eye disease. So we are talking about the surgical retina. So we have eminent speakers here with us today. We have Professor Armin Wolf from Germany. He is very eminent retinal surgeon and very well known in the Western world and whole world. We have Professor Ashraf Sharawi, Egyptian, very well known, very good friend of us, very good retinal surgeon. We have Professor Natarajan Sundaram. He doesn't need much introduction, so most of the us knows him, and he is very good and famous retinal surgeon. We have Dr. Marco Mora from Italy. He's currently working in Riyadh, so he is very eminent and very well known retinal surgeon. We have Hani Hamza, our very dear friend from Egypt, very well known retinal surgeon, and he is much of doing about the TRDs. So we have George Roca. Everyone knows him. He is the most famous now around the world. So we welcome him, and very good retinal surgeon, a very good friend. Hi, George. So can you hear me? If everything is fine, so we can start with the Professor Armin Wolf, and he's presenting today surgical approaches for pathologies in diabetic retinopathy, vitrectional retinal detachment. Professor Armin Wolf, please start. Thank you.
Okay, it seems that you have disabled screen sharing. Can you enable it? I cannot screen share. Can you enable screen sharing, the host?
Yes. Yes, please, you can start now.
Thank you very much. Dear John Paul, dear Hossein, thank you very much for the invitation. My talk is going to be about pathology and fractional retinal detachment. And well, first, if we look at it, then I think it's important that we know how often are we going to deal with it. But there is not exact epidemiologic numbers, but we can look at the numbers of indications that we have. And the most frequent indication for surgery in diabetic retinopathy is persistent or recurrent vitreous hemorrhage. Meanwhile, recent data also by Bressler indicates that early vitrectomy is more cost effective, and anti-VEGF therapy presumably does not lead to tractional changes. So anti-VEGF is very often given in case of vitreous hemorrhage. The next frequent indication is a tractional component in a diabetic macular edema, and we all are aware of the incidents. Tractive retinal detachment in PDR is less frequent in the indications that we see. However, we do observe it, and it poses severe implications for the surgery. It becomes even worse if it is not a pure tractive retinal detachment, but if it's a combined tractional and Rigmatogenist retinal detachment, so-called CTRRD, because then the surgery gets more difficult with a more mobile retina with tractive membranes. It does have a more poor prognosis than just the pure tractional retinal detachment, and the pathogenesis is different than in a pure Rigmatogenist retinal detachment. Because it may occur in attached vitreous, and very often we do have, and the idea is that the number of a conversion of tractional retinal detachment to combined tractional Rigmatogenist retinal detachment during surgery is underreported. So very often during the process of surgery, it may occur that the hole is generated, reducing the prognosis. These occurs because during the preparation of the membranes, there's lamellar tractional forces during PDR surgery, and these may induce holes. If we look at other tractional retinal detachment, and I'm very aware that this is not the same disease, it is very evident that tractional membranes have a clear and distinctive way they grow. If we look at the ROP surgery, membranes actually develop in a very distinctive way. it's a almost unique development of the retinal detachment. You do have a ridge-to-ridge, which is often referred as the drumhead. You have ridge to the ciliary body, AP tractions. You have optic disc to ridge. So you have a central stalk that you will not observe in tractive retinal detachment in PDR. However, it is more than evident that the diabetic changes are not comparable to ROP. We do have a different vitreous in ROP surgery. We have an immature retina, and the TGF level depends highly on the age of gestation. In PDR, we have diabetic changes of the vitreous that you can clearly observe. We have also very distinctive biochemical changes. We know that in vitreous, in diabetic vitreoretinopathy, we have induced factors such as gremlin or adiponectin, which induce, in the presence of VEGF, a very fibrotic response if VEGF drops. Very often, the drumhead structure that I was referring before in retinal, in ROP surgery is often observed. You can observe this drumhead structure like between the membranes before the macula, and you can observe it during the surgery. This is due to the fact that while we believe that vitreous is a gel, it's not a gel. It is actually a complex system of unique cysts and cavern, and this idea has been brought up by Jan Horst. And one of the most eminent is the Premarital Bursa, which exists, and actually we are currently looking at pathology-specific changes, such as the Premarital Bursa, giant Premarital Bursa in Stickler's disease. This is also due for the for diabetic changes. If you look at fibrotic changes, they lead to specific cysts in the development of typical traction. You always see these tractions surrounding from the diabetic membranes of the vessel arcades. So if you have a general approach for tractional retinal detachment, or also combined tractional Rigmatogenist retinal detachment, the first step that you do is you create a cone with a dissection of the peripheral cyst walls, leaving you some space to come on the posterior pole and work on the drumhead-like structure. The creation of the pole with a dissection of peripheral cyst walls is one of the first things that one actually does in the resolution of tractional membranes. Next thing is the fragmentation and segmentation of membranes. This is a step that we actually do in preparation of these membranes to avoid uncontrolled exertion of tangential forces, which are blamed for the development of holes in the retina during the surgery of a tractional retinal detachment. And you can see here in this video, if you cut these, and many of us may use a small gauge cutter in these steps, you see how they separate by themselves because there's a lot of rigidity in those membranes. And by just cutting them in half, you realize that the traction is released. Possibly this step can be performed by a Bimanual approach. However, for my part, I'm using a mono. I use a light pipe because I'm just used to it, and I don't like the chandelier light. Now, the next step would be the delamination and the mobilization of membranes, along with the cauterization of membranes of feeder vessels. Very essential, and if you look at the architecture of fibrovascular membranes, it is important that you move from the fibrovascular membranes from the retina side, because this is actually where they grow from, and this is where they have their feeder vessels. They have a very large network of vessels, as you can see here, but the deeper you go, the more closer to the retina you go, then you see that there's usually 1, 2, or 3, just a limited number of feeder vessels that you see for these membranes. And then you can do a very punctual cauterization of these feeder vessels and using the scissors for cutting and having a reduced hemorrhage. You can use now for delamination and extraction of these membranes, you can use the backward shaping technique, viscodelamination, or also proportional reflux delamination. There's a lot of techniques being currently developed. And many of us, it depends very much of the setting that you have, many of us use different techniques. Overall, you may say that it is important while you do tractional changes in vitreous diabetic retinal in PDR, it is important that you remember vitreous is not a gel. It's fibrotic cysts and caverns that exert lamellar forces, especially in PDR. Following these structures during the surgery may avoid anterior posterior tractions and thus avoid the conversion of tractional retinal detachment to combined tractional Rigmatogenist retinal detachment. The steps that we follow is preparation, mobilization of and segmentation of membranes, delamination and resection of the membranes. Recent techniques aim at at the lamellar approach. So this way you may use small gauge vitrectomy or mixed gauge systems and then knighted prick backward shaping technique, bimanual preparation, viscodelamination and dissection, or proportional reflux hydrodissection. I hope to see you live very soon with the corona situation getting over. Until then, if there's any question, please feel happy to contact me. Thank you very much.
Thank you, Armin. Any questions from the panel? Yes, Hussein.
So, Armin, it was nice presentation, and the idea of that it's not a gel and it's a bursa or caverna. I think it's quite applicable. But my question is that do you prefer to do PVD before your segmentation and delamination, or you first do the segmentation and delamination and then you lift the posterior highlight? What's your preference? Because both techniques have some limitations. So,
yes. I try, well, very much depending on the situation, what it looks like, but it's a severe tractional retinal detachment. I avoid doing a PVD in the first steps because this is actually when I extract the forces and convert it to a Rigmatogenist combined retinal detachment, and thus reducing the prognosis. If you stick, if you manage the surgery sticking to a only tractional detachment, you do not need silicone oil. You can wait until the subretinal fluid disappears, and you possibly need to rinse the eye once more, do another vitrectomy and take out the blood. But very often you will not find yourself in the need of silicone oil. So this is actually, I try to avoid doing the PVD with severe tractional retinal detachment.
Okay, you just do the segmentation and delamination, and then if you feel that the PVD induction wouldn't create any break, iatrogenic break, so then you can do. Otherwise, you usually you leave it. Yeah.
Yes. Yes. This is why you need to prepare the cone on the back. Otherwise, you can do a peripheral PVD, which is difficult to grab the rim of the cortex.
Armin, no, thank you. You mentioned something which I think most listeners will find interesting: the fact that injecting anti-VEGF doesn't really affect traction, and this is something which is very much feared. It's a common, I would say, idea that once you inject, you have to go in and do surgery because you will get traction and you will get detachment. Can you comment a bit further on that? Because
Yes, well,
bleeding is our main issue, isn't it? I mean, we're
yes,
all afraid of bleeding. So if we can get
yes.
avascularity, we're very happy.
Well, that's based on the data from the DRCR nets, where they did a meta-analysis actually and looked at how often retinal detachment occurs. I particularly don't like the idea of injection anti-VEGF agent on a retina that I don't know what the traction looks like, because it does not say it does not occur. It says it occurs very, very infrequent. But as for my side, if it occurs, then it's a very disastrous surgery. It is very complicated. So then looking at the data, I think there's a lot of uncomplicated tractional surgeries. I, for myself, I do not do an anti-VEGF injection if I'm not able to judge the retinal traction.
So if you have blood, in other words, if you have blood, you don't inject. If you have a vitreous hemorrhage, you do not inject because you don't know what's underneath, correct?
Yes.
So that's an important message to pass. Yeah.
Yeah.
Thank you.
Do we have any other question from the speakers?
Can I add some comment? I think if you have blood and you can see that there is no traction on the retina, then you may inject. I mean, it's not absolute, but if you cannot verify that by ultrasonography or otherwise, because I see some patients have a mild vitreous hemorrhage, you can see still the retina, and you still hope that you inject and it clears and you do laser and avoid surgery. So it all depends on how much you can judge the amount of traction that is there.
I think we meant massive vitreous hemorrhage where there's no visible retina. So, and sometimes the ultrasound would not give you the information you would like. Yeah.
Yes.
So, Ginny, can you proceed?
Yes. Yes. Let me just catch up here. So next we're going to be having Professor Ashraf Sharawi from Egypt, bimanual surgery in diabetic vitrectomy, and he will be giving us his experience, which is vast, on tips and tricks how to do this. Ashraf?
Good morning, everybody. It's my pleasure this morning to be sharing with you in this distinguished panel about the management of advanced diabetic eye disease. Recent advances in surgical technology and technique had improved the safety and efficiency of surgery for traction or combined Rigmatogenist retinal detachment. Bimanual maneuver used in small gauge vitrectomy, recently developed vitrectomy machine and wide angle viewing system had improved our capabilities to deal with the chances of complications with these challenging diabetic patients. A chandelier endolaminator allowed the surgeon to simultaneously manipulate scale depression and use the vitrectomy probe, enabling dynamic coordinated peripheral surgery that is more controlled and efficient, and very well conferred to an improved margin of safety. Bimanual surgery in surgical circumstances, surgeon may prefer bimanual surgery rather than having one hand occupied with an endolaminator. And as you can see in this advanced PDR cases, although we have very high speed cutters reaching up to 7,500 cuts per minute, but still in some cases in which we have a hard plate or tabletop fractional retinal detachment, there is difficulty in getting the vitreous cutter in the cleavage line between these hard plaques and the retinal surface. And in these particular cases in which we need bimanual surgery so that we can find our way through the cleavage line. At the beginning of the chandelier or the bimanual surgery, Illuminated infusion cannulas were used. However, they have weak light, shadow casting on instruments, competent assistant to direct the cannula to the area of dissection, large gauge of cannula, and with incidence of iatrogenic cataract during maneuver of the infusion cannula. So, does the pars plana light sources provide adequate illumination for bimanual work? Yes. But we have to choose the right tool to reach this light to the surface of the retina. One of the best tools, which I found very helpful in my hands, is the Ecker twin light chandelier, which gives light from both sides of the illuminator so that we have some consistent lighting all through the vitreous space. Why do you need bimanual surgery in diabetic retinopathy? It shortens the procedure. There is faster removal of triamcinolone particles after staining of the posterior hyaloid, bimanual dissection of epiretinal membrane. Sometimes we need it in eye lamp peeling in fractional diabetic macular edema, faster and complete air fluid exchange, immediate extraction of fibrin, blood on the surface of the macula, more peripheral application of endolaser up till the oral strata by scleral depression, easier detection of sclerotomy-related breaks, dissection of anterior hyaloidal fibrovascular perforation. And I will show you in the next few videos how this can work. As you can see, this is a case of a combined traction Rigmatogenist retinal detachment. If you have one instrument in the eye, like the vitreous cutter, you will take some time to remove these particles after staining. However, if you have a flute needle in the other hand, you just can backflush the particles and highlight the area of traction, shortening the timing of the operation and shortening the timing of dissection. Again, bimanual dissection of epiretinal membrane, in which a curved scissors is used to find the cleavage line and find the epicenter to separate the perforation from the surface of the retina, with less incidence of iatrogenic breaks and less incidence of trauma to the retinal surface. Not always we need the scissors, but sometimes in very tight adhesion, we can use the end gripping forceps with the vitreous cutter just to find the plane and the cleavage line and the epicenter between the perforation and the retina without the use of the scissors. This shortens the procedure and again gives safety to remove the fibrous perforation without creation of iatrogenic breaks. Again, dissection in this advanced combined traction Rigmatogenist retinal detachment, in which the retina is completely mobile. You have to remove this epiretinal perforation without exerting more traction on the surface of the retina, and then you can get the retina back in its place and apply your endolaser. Sometimes in peeling of the eye lamp, you may need an instrument like Litano scraper to create an edge and use the eye lamp forceps to go with the rexus like pattern of removal of the eye lamp. Sometimes the eye lamp is very adherent to the retinal surface. At one point or another, you may need the Litano scraper to create a new edge or to help or assist in pushing the removal of the eye lamp without again exerting traction on the surface of the macula. Another case of tractional diabetic macular edema and eye lamp removal. After creation of the edge of the eye lamp, you can use the forceps safely on the edge created to remove the rest of the eye lamp from the macular surface. Faster and complete air fluid exchange. After removal of traction, you have to remove the subretinal fluid using both instruments inside the eye, one flute needle in the site of the iatrogenic break or the drainage retinotomy, and the other cutter, vitreous cutter, just in front of the optic disc. You can finish with complete air fluid exchange and faster and complete so that you can apply your laser safely. Sometimes the fluid is so viscous that its removal by one instrument takes very long time and delay the procedure. Another issue in diabetic retinopathy is the collection of blood during dissection of epiretinal membrane. And this blood and fibrin turns immediately to a fibrin glue-like structure, which if you don't remove it immediately during the dissection, it may be very difficult in the late case to remove it from the surface of the retina, and sometimes it's more hard to remove it than the original fibrous membrane. Having two instruments inside the eye, one with suction like the vitreous cutter, you can immediately flush the blood and the fibrin from the surface of the macula. Again, endolaser can be applied up till the ora serrata, which is a very important issue in ischemic types of diabetic retinopathy, in which this regress the formation of rubeosis iridis or anterior hyaloidal fibrovascular proliferation. Again, some complicated cases of diabetic retinopathy in which there are atrophic changes in the retina and you cannot see the cause of recurrence. By using scale depression, you can find that there is a very small pinpoint break in the retina, which is the cause of recurrent retinal detachment. Dissection of anterior hyaloidal fibrovascular proliferation, which again is an important cause of recurrent vitreous hemorrhage from the periphery of the retina after successful vitrectomy. If you don't remove this proliferation from the vitreous base by using scale depression, you may get recurrent vitreous hemorrhage and recurrent problems. Again, some cases of the advanced diabetic may be complicated by PVR and proliferation. If you are in the setting of bimanual surgery, you can immediately judge the extent of the retinectomy you need, and you can remove all the bridging vessels that prevent the reattachment of the retina. And after complete cutting of the fibrous tissue, you reattach the retina by using perfluorocarbon. Again, direct perfluorocarbon silicone injection and under direct vision, which is an important part while having a chandelier inside the eye, you can remove the very small bubbles of the PFC under vision so that you cannot get residual subfoveal or subretinal PFC bubbles inside the vitreous cavity. Again, in silicone oil removal after the successful retinal surgery, there is direct silicone removal under vision, scleral depression very easily to examine the peripheral retina with decreased incidence of recurrence. In conclusion, for tightly adherent fibrovascular membranes, bimanual techniques are often necessary to achieve tissue separation. This can best be accomplished by using chandelier lighting systems. Typical bimanual instruments used to dissect fibrovascular membrane include forceps and scissors. However, several combinations depending on the pathology at hand are available, such as forceps with vitrectomy probe, which can be more efficient in many cases. Diabetic dissection is mainly based on scissors rather than peeling. However, peeling may be needed in combined traction rigmatogenist components with PVR and in cases of premacular hemorrhage with tightly adherent hyaloid. Thank you very much for your attention.
Thank you so much. We had no doubt it would be an outstanding presentation, and it was. Thank you so much. Do you have anything to add to this, Hussein? Do you?
So it's Professor Ashraf, very nice presentation, and you showed very difficult cases how to manage intraction and rigmatogenous retinal detachment. I have a very few humble question that do you prefer to peel ILM in every case of your traction retinal detachment?
No, I don't prefer to remove the ILM in all cases. I just remove the ILM in visible traction on the surface of the retina after the vitreous surgery. So it's an intraoperative decision, and it depends on the presence of visible tractions or visible stria, but not in every case, because removal of the ILM is not without a price. You may have trauma to the nerve fiber layer. You will have the so-known Domfil or Somfil effect of removal of the ILM, which may decrease the visual outcome of the surgery.
Okay, so my question continues with the same, that how many of us have the incidence of macular hole later on secondary macular formation in if we peel ILM in tractional retinal detachment in diabetic eyes? Do we find macular hole incidence?
Excuse me, I didn't catch the question.
So question is that if we peel our internal limiting membrane in tractional retinal detachment, do we find formation of secondary macular hole in those eyes later on?
Yeah, this can happen. And that's why I'm not insisting on removal of the ILM in all cases, because this can happen especially in diabetic retina with the ischemic components. The trauma of the removal of the ILM may end in formation of a full thickness macular hole or a lamellar macular hole. And this would jeopardize the visual outcome of the surgery.
I think you made some very good points, and I'm going to ask the panel in a second if they have any other questions, but I would like to highlight something which I think is important. When the small gauge instruments came out, many people were saying that bimanual surgery was no longer needed. Now, diabetic retinopathy is a very diverse condition. You can have very different stages and very different presentations. Also, the retina can be more or less ischemic and therefore very fragile. So the fact that we do still need bimanual surgery to reduce the amount of traction which is exerted on the retina is absolutely paramount importance. Plus the fact that, as you pointed out very well, even small gauge cannot get into certain spaces, and it cannot really allow for segmentation. So again, that is a very important issue to keep in mind. The chandelier, which you have shown, gives good lighting because it comes from two different directions, and so you don't need to actually orientate it as you would with a single light all the time. The only thing that one has to keep in mind is that it has stoppers, silicone stoppers, which have to be properly positioned so that if you have a phakic patient, it doesn't touch the lens, correct? Any questions and comments from the panel? Because you have the expertise. Please go ahead and give us your ideas.
I have a question.
Yeah. Let's go in order. So I see Jorge, and then I've seen Armin, and I've seen Annie. Marco, did you have a question? But let's start with Jorge, please.
Professor Ashraf, thank you very much. Brilliant presentation. I just have one question. It was so nice in your hands to perform the bimanual, but which scissor do you prefer? Horizontal, vertical, angle, and what gauge, 23, 25, what's the best tool you think for these maneuvers?
Well, I prefer the 23 gauge scissors, which is curved with the bend of the blades coming in the angle of the fibrovascular perforation. And usually I don't use it much. So the use of the scissors is very limited, but still we needed in some cases of very adherent epiretinal proliferation. And the curved scissors is the best. I don't use vertical scissors anymore, only curved scissors and 23 gauge in gauge.
Thank you.
Yes, Armin, please.
I just want to comment or wonder on the questions concerning the ILM peel. There is data that ILM peeling helps in diabetic macular edema. And I think what we are doing in severe tractional retinal detachment in PDR is we are always trying to get everything done in one surgery. And that, from my point, I think it's sometimes can be dangerous, because the first thing that we should do is not harm the patient. And so we must see the patient is coming from a severely damaged eye. And we are wondering if we need to do the ILM peeling or not during the surgery. And very often we cannot adequately judge the retina, the hypoxia, and the danger of a full thickness macular hole developing from when we do the ILM peel. So I wonder if for the audience, a two-step approach, that in the first step you do the tractional retinal detachment and try to settle it down as much as possible. Then maybe 4 weeks later, 6 weeks later, do an OCT scan, evaluate the outer retinal changes, and then re-itinerate if you are going a second surgery for ILM peel, if the patient has a benefit of it.
Annie?
Yes, Armin, you raised a very good point that, I mean, a two-stage surgery can be very wise, especially that when you release traction, in many of these cases, the macula unfolds and the traction lines disappear after a while. And many of these cases need silicone oil injection. So during the second surgery, you have ample time to decide whether to remove the ILM or not. The second point I would like to comment on is to highlight the role of bimanual surgery, as you did, Gianpaolo Gini, because this depends to a large extent on how broad is the area of fibrovascular adhesion, and if the retina is folded behind this fibrovascular adhesion. Because if you go with a unimanual instrument, you may very easily induce an iatrogenic break. So in many cases, we start with a unimanual surgery, and then you stop at one point and decide to go for a bimanual surgery. So it's not over with bimanual surgery.
Absolutely. May I also add that vitrectomy may change the trophism of the retina, because it can actually get some better oxygenation of the retina, so that the idea of waiting in between the two surgeries several weeks is definitely the proper approach. So it should be a two-step procedure. Hussein, I think you have something to say?
Yes, I have a little bit controversial question, maybe. So it's about the bimanual surgery. I agree, it gives you much freedom for light visualization. You have a freedom to cut with the both hands and to peel. But don't we think that with the bimanual surgery, to make it short, surgeon become more furious and he pulls the retina more than if you are going for unimanual surgery? Because when you are doing bimanual, I have seen, I do myself, I prefer to do bimanual, but even with the bimanual, we have intentions to cut it more furiously, more interventional, and I feel that during my surgery I pull the retina much more than when I do segmentation or delamination unimanually. What's the comments of the panel? I would like to listen about it.
Marco, you had something to say? A comment on this, maybe? I think you're you like monomanual. Is that correct, or am I wrong?
Both. I mean, I think every case,
Okay.
as you pointed out, the disease is very heterogeneous. So there are cases which are very well approachable with unimanual, and cases which are approachable by bimanual and are impossible to do unimanual. So I think you should be using both. Coming to the question of Hussein, I mean, I like to remove all the fibrovascular tissue. So if I cannot do that with unimanual, I would go definitely bimanual. I don't know why. I mean, I don't think you should be. It requires patience, and but what you said, probably because you tend to remove all the tissue, it looks like you are more furious, as you said. But I don't think that is necessarily the case. It's just you're trying to do your job properly and removing the scar tissue. So just try to be calm. I don't have any other solution. You know.
Okay. Nati, any comments?
This is not Nati. This is somebody else.
I see someone else. He's improved with time.
Sorry, Natarajan sir has just gone for a quick emergency. He will be back in about 2 minutes.
Okay, right. Okay, thank you. Hussein, do you think we should carry on? Because we do have 2 hours, but they go rather quickly, yeah?
It may take more longer than 2 hours.
If we get into discussions like this, yes, definitely. But they are very interesting. I think in the end, the audience can take away different ideas and tips. And as you all pointed out, it is such a diverse disease that really every surgeon will find a situation in which he needs one approach or the other. And knowing all the approaches is very useful, because this way you can deal with most of your cases. So shall we go on, Hussein? Shall we introduce the next one?
Yes. So next we have Natarajan Sundaram, and he's presenting fantasy of 3D.
Maybe we can skip. Maybe we can skip him now because he's busy.
Can I request you can go to the next talk, and then after the
Yeah,
next talk?
yeah, sure.
Okay, got your point. So we have next speaker, Dr. Mora from Italy, and he is presenting surgical strategies in diabetic fractional retinal detachment. Mora, please.
Which is very fitting to what we just said. Yes.
Yes, I think. Wait a sec. Let me share. Okay. Am I sharing?
Yes, it's fine.
Okay, let me see. Can you see my screen?
Very well.
Okay, thank you very much. I have to try to minimize this one. Okay, great. So thank you very much for this invitation. I will try to talk about some surgical strategy in diabetic fractional detachment. We discussed very recently, just now, that the disease is very heterogeneous, and this is a kind of an attempt to describe some of this and to classify this diversity of the pathology. As we said, not all diabetic fractional retinal detachment are the same. There are some more simple ones and some more complex ones. This is how we try to classify them in 5 stages. Let's say from stage 1, which is the most simple one, with some vitreous bleeding and one focal point of attachment, going to the stage 2, where the focal attachments can be multiple, passing then to stage 3, when the focal attachments are not only multiple but are also broad. And I think here is the main complication of the disease, when the attachment becomes broad, because when the attachments are very focal and not too broad, the disease is much easier to address. Going then to the stage 4, where the adhesions of the vitreous are much more extensive, and only at the posterior pole there is some detachment in the macular area. Going to stage 5, where the posterior hyaloid is totally attached to the retinal surface and the retina is detached under it, which is the most complex pathology to treat. Another point of discussion and very important to address is the amount of vascularity. We touched at the beginning, vascularity in addressing fractional retinal detachment is an essential factor, because also here we have a lot of gradation of the disease. We can go from a total avascular fibrovascular tissue, like in these images here, where there is no vascular component. These cases don't need, for example, in my view, anti-VEGF prior to surgery. because there is no really active vascularization that need to be addressed, so they can be treated without preoperative anti-VEGF. And there are cases with mild, moderate activity of this vascular tissue, which in my view, they require anti-VEGF, and we can discuss later how long before surgery we have to give it. And I'm sure all of us will have a different opinion about this. But I think that anti-VEGF in these cases is kind of mandatory to make surgery simpler, avoid intraocular bleeding intraoperatively, and make the surgery smoother. And there are cases where the vascularization is very severe, like in these cases where anti-VEGF not only needs to be given, but also the time frame of giving the drug needs to be addressed properly, because we don't want to still have bleeding during surgery if we do it too short before the surgical procedure, but we don't want also to create traction after the injection if we leave the anti-VEGF too long in the vitreous cavity. Remember that, and it's something we see in the clinical practice, at least I see it a lot, if there is a big vascular active component, this will tend to become fibrotic, and this fibrotic will stretch on the retinal tissue, increasing the retinal detachment. So I'm really, it's something we see it every day in spite of what the clinical study said. So what are the goals of the diabetic vitrectomy? We saw it in the beautiful videos of Professor Ashraf. It's to remove the anterior posterior and the tangential traction, and we have to try to do this avoiding possibly or at least minimizing iatrogenic retinal breaks. In doing this, is essential to remember that diabetics have almost universally something which is called vitreous schisis, which means that the vitreous is not separated like we used to see in other pathologies from the retinal surface, but almost always it has two-layer separation. The posterior vitreous, the posterior cortex is not separated totally from the retinal surface, but can have a lamellar vitreous detachment. Another important point is we have to try to do this maintaining hemostasis, and in this we see that I just mentioned it, that anti-VEGF it's in some cases mandatory, and of course try to prevent recurrences while we're doing this. This is how do we relieve traction. I will go very briefly on this. There are two techniques we spoke before, so we'll go fast. One is unimanual, can be with scissors, vertical scissors, for example, and one with a cutter, and the bimanual dissection, which can have combination of segmentation and delamination techniques. This is what we advise. I mean, just to, coming back to the classification previously said, when we have cases, at least that's what we do, when we have cases of focal TRD, when there is no Rigmatogenist component, like the stages 1, 2, and some of the 3s, when the adhesions are not too broad, we like to do this dissection with the vitrectomy. And keep in mind that this type of approaches can be present in both like unimanual and bimanual in the same patients. This, of course, is very easy nowadays with the new probes, especially in the smaller gauge, because the opening is very close to the tip. We heard it many times. So in these cases, it's much easier to approach it unimanually, and usually we go for it. It's a fast surgery, very clean. You have to be careful, as mentioned before, also by I think by Gianpaolo, when the retina is ischemic, and unfortunately in the Middle East we have a lot of ischemic retinas, especially young patients. I don't like to use the cutter in those cases, because I think that the retina is very ischemic, is very thin, and the membranes above the retina, which are pulling the retina detached, are very strong. So using the cutter in those cases, you may end up aspirating your retina in your port instead of removing the traction. So in that case, I like to use scissors. Segmentation technique, separating then the membranes in the bigger membranes in islands, separate islands. We use it when, and then the bimanual approach, we use it when the retinal detachment is large with broad adhesion. So some of the stage 3 and stage 4 and 5 definitely are, for me, at least in my hands, bimanual techniques. Also, when the retina is detached due to a Rigmatogenist component. I like to do a bimanual technique because I find the retina very mobile, and I don't like to approach it with a cutter. Where I can, of course, adjust the suction, but I find it more dangerous because, as I said, the retina is thin and ischemic, and mobile, and the fibrovascular tissue is very rigid. So this is a very critical association which can give you breaks in the retina when you don't want them. So in this case, I like to use bimanual surgery, and I divide the islands in smaller islands, and I attack them separately with the scissors and forceps. This is a kind of summary of what I just said. So I like to complete the membrane removal totally. I don't like to leave any tissue behind. Personally, I do not remove the ILM during the first surgery unless there is a clear pathology in the macula, like some tractional macular hole, for example, of a real evident fibrovascular tissue above the macula. My bimanual technique, I will show it in some videos now, it's a 4-port vitrectomy, and I use a single fiber, which I always position on the inferior nasal quadrant, and I fix on the nose bridge, and it gives a very nice light. In some cases, we consider retinectomy when there is a peripheral tractional relief. To be honest, with the bimanual technique, is rare to have this, but in some cases of combined detachment, still you can have it, and some scleral buckle very rarely if we don't want to do retinectomy. Another important thing I want to stress is visualization. I like very much to use the 3D in this patient, especially because I can get a much higher magnification of the surgical field without losing resolution. And it helps really to remove, to segment, to peel, and to remove the membrane, because in my view, the best way of preventing hemorrhage is also to do a careful dissection and avoiding cutting blood vessels, which they shouldn't be cut. This is one example. This is a TRD, quite easy with some vitreous hemorrhage. I use this just to show you the advantages of a 3D. For example, you can see here, if you use a red-free filter, you can see much better the fibrovascular tissue compared to what you would be seeing if you do use the normal analogic microscope light. You can see it's very clear. You can see here the difference. You can go ahead and dissect the fibrovascular tissue, in this case unimanually, with high magnification, I think in a safer way using this filter from the 3D system. Also see the magnification is much higher than compared to what you would achieve with a normal microscope. It's higher magnification without resolution declining, which is something which we cannot achieve with the normal microscope. Look, here I'm doing unimanually. I'm checking these membranes with a cutter, because these membranes are actually quite soft, and it's easy to do a backfold delamination with these ones. When this membrane become more stiff and the retina is detached under, it is more difficult to do this maneuver. So in those cases, as I would do just in a couple of seconds in this video, I will have to switch for a bimanual technique. I find it safer and more efficient even than the backfold. But the backfold for sure works very well in this particular step of the surgery, because the membranes are very, very soft. You can see here the membranes are much stiffer and much more adherent. So we switch in the same patient to a bimanual technique, and we we separate the fibrovascular attachment from the retinal surface with the forceps, and we make space with the scissor. Sometimes I use the scissor as a spatula. These are the Dork 23 gauge scissors, which in my view are the best for a bimanual dissection. They have a perfect curvature. They have a long shaft of the tips, and really you can use them as a spatula, and not only as a scissor but also as a spatula to remove these membranes. So we go to the next video. This is also a video where a very ischemic retina with a very broad fibrotic plaque. Oh, something is wrong. It's going very slow. Sorry, if you don't mind, I will try to play them from outside. Sorry, because I think there's something wrong with the video. Is it? Can you see me now? Okay, let me check.
It's gone.
It's gone. Okay, wait a sec. I don't know why. I'm sharing it through my desktop. Can you see now?
We can see it.
Okay, here a broader tissue you can see, and I am basically trying to delaminate it first with the scissors. As I told you, I use the scissor as a spatula to be able to. I have some delay in the video, guys. Do you see the same?
It's a little bit slow streaming.
Okay,
but
Shall
it's
I try?
okay. It's okay.
Shall I-
Don't. I wouldn't
Shall I-
worry. It's very interesting.
Okay.
Even
just
if it's slow, doesn't matter.
I can try to play it from outside. Maybe it's better.
You can talk more if it goes slower and explain more.
Okay, wait a sec. So, do you see anything, or you see myself? What do you see now?
We
don't
see
see your
nothing.
You see nothing? Okay. Let's me desktop share.
Okay, we see the video.
Okay, let's see if it goes. You see the plaque is quite broad. So in this case, and the retina is very thin. So I use the scissors to delaminate it first and divide it in smaller islands, because going here with a cutter would mean creating a big break under the retina. The cleavage plane is very, very narrow. So in this case, introducing a vitreous cutter inside and start to cut would mean probably cutting this very ischemic retinal tissue under. So you see, I use the scissors as a little pick, and these dark scissors for me are really what I like the most. Once I find the cleavage plane, I lift it and then I remove it with a cutter or with the scissors themselves. In this particular case, the fibrovascular tissue was going right into the foveal area. So we have to be very careful in dissecting this tissue before removing it with a cutter. And the last piece I did also here with the scissor. I didn't want to go and create a macular hole iatrogenic into the fovea. Also, in this case, if you manage to do this surgery without iatrogenic breaks, it makes your life much easier, because you don't need to drain, in my view, because the RP pump will make, in this case, I didn't make any iatrogenic break. I just put air and the retina went flat on its own afterwards due to RP pump. That's it. This is a more complicated case with some Rigmatogenist component. I go a little bit further with some phaco, it's not interesting. Okay, you can see here there is a total attachment, only the macular area, probably there is some space, some cleavage plane. So we try always to truncate the peripheral vitreous, in this case, schitic vitreous. I'm using here pneumatic forces that to show you there is an option, especially if you have, you can use them when with your left hand, if your right hand is a dominant hand, and sometimes using the pneumatic scissor helps because it minimizes tremor with your non-dominant hand. This is just an option I'm showing you here. I mean, some people like it, some people don't like it. They are pneumatically activated with your foot pedal, so there is no trilling with your hand while you are doing this maneuver. You can see here there is a combined Rigmatogenist fractional detachments with all adherences into from the posterior pole to the periphery. This is mandatory, of course. Bimanual surgery is unthinkable to do this with a cutter. In fact, I started with a cutter. You can see I created a nice little round break there due to that too much aggressive action of the cutter itself. While with the bimanual surgery, delicately, you can dissect these fibrovascular pegs from the retinal surface and eliminate the traction in a much more controlled and efficient way. instead of avoiding all the bouncing and the risk of creating retinal holes. This is a long process. I go a little bit further, just not to bother you. In this combined, of course, we like to use also some perfluoron just to flatten the posterior pole, so we can remove better the membranes anteriorly. You can see those membranes, they were just going up to the ora serrata. And here it takes really a lot of patience to be able to effectively remove them. And as I said, you need to remove them all, otherwise there will be contraction left and possibly also some rebleeding. This is just to show you there are some nice lasers you can use to coagulate also extreme periphery due to the articulating movements. You can see after flattening the retina, removing all the tissue, we did PRP and we tamponate this patient with silicone oil. This is another case where there is also a Rigmatogenist component, very young, very massive fibrovascular proliferation. Also here we are truncating the posterior schitic hyaloid. And then after truncating, we go and we attack from inside out this detachment. Here the retina was not only full of fibrovascular tissue, but also subretinal tissue. Another instruments you can use to dissect the peripheral membranes is the illuminated PIC, as you saw here, just to separate this tissue from the periphery. And again, using the perfluorocarbon to flatten the posterior pole, we can work easier into the peripheral retina, removing this aggressive fibrovascular tissue and try to flatten the retina in an efficient way. No tolerance for vitreous remnants also posteriorly. Here I'm cutting away. You can see the retina was folded like a sandwich due to this anterior fibrotic tissue. So we are slowly, sometimes I like to use in the periphery the straight scissors because I think they cut a little bit better on the tip and they help to dissect this tissue in an efficient way. This is some subretinal membranes was present. We had to remove it to be able to flatten it. And then we do PRP and we tamponate with silicone oil. I think this was my last case. Thank you very much. Sorry about the video problems, but I don't know what happened.
So
I think we're all very happy, even with your video problems. They were very, very good. Thank you.
Thank you, Dr. Mora. It was very nice presentation by you, and you showed your bimanual and complicated cases too. So do we have any question regarding Dr. Mora's presentation?
I have a question.
Please.
Marco, so most of the surgery you've shown, which is very, very nice, obviously, as usual, you had very little bleeding because obviously these were mostly avascular cases. So partly because this was atrophic retina, but also you obviously treated them beforehand. And now you were mentioning the fact, and I stress this because there is so much controversy on the time frame for anti-VEGF. What is your particular time frame?
Yeah, Gianpaolo, as I said, it's very heterogeneous because the amount of vascularity, as I show it, it changes between patients very much. So when I see retina which are very florid and vascular with big vessel of a large caliber, I tend to give the Avastin at least 1 week in advance. Because if you do it too shortly before the surgery, you will end up having a lot of bleeding. So I think the amount of time depends on how much vessels are present. On the other end, if I have a case where the amount of these vessels is not so much present, and we try to do a study checking with the wide field the photographs with the optos to see if we could understand how many sectors or how many disc diameters would that be. It's very difficult because sometimes the blood vessels are also hidden behind the fibrovascular tissue. We don't see them very well. But for sure at least 3-4 days before surgery when it is a moderate amount of vascularity, and a week or even more if there is really a florid disease. And to be able to standardize would be great, but it's not easy.
I have a question.
Yes, please.
Yes.
Yes, Marcos, beautiful surgery. I'm very impressed. And I'd like to know, I think you said when you do not have any break, you just leave the subretinal fluid by themselves.
Yes.
And I agree completely with you. I do the same. But when it's very ischemic case, if you have fluid, you can't do any laser. Sometime I finish the surgery and inject again on PGF, just to wait a little for the fluid goes out, and at the office I can laser again. What is your approach when you leave some fluid underneath the retina?
I leave some fluid. What I do usually, I do air fluid exchange. The fluid, if the retina is totally detached, I do air fluid exchange, and the fluid collects posteriorly, so I'm able to do laser on the periphery of the retina. If I map in this way, I would leave it like this, and then I will go further afterwards in the clinic to do some surgery at the posterior pole. Another way to do it would be to remove the fluid from the sclera, to do a posterior sclerotomy and remove fluid. But in my view, really, it's not really necessary, because even when the retina is ischemic, really, it tends to reabsorb on its own in probably the majority of the cases. Rarely I had to go in and remove fluid. Usually it disappears, even if it takes some time. So as I said, I tend to leave it, and I do the laser on the periphery if I can, or I will do it later in the clinic.
Yeah, Gianpaolo, can I make a comment?
Yeah, Nati, of course.
Yes.
Yes.
Okay, you are very smart now. Very nice.
Yeah, oh,
as
you
usual.
look very. Are you going to a wedding?
No, so I think I'm happy. So I'm happy both Marco and Gianpaolo are here. Now the next is George has to travel to Mumbai, because Marco and Gianpaolo was in Mumbai. So
My pleasure.
When we still could fly.
Yeah.
And so no, the comment is beautiful surgery. And all the time I wanted to go to Netherlands when Marco was there. And Marco, where are you now? You are now in Saudi?
I'm now in Saudi, yes.
Yeah.
Okay, so it's only 3.5 hours flight from here.
Yes.
So we should go. I think we can.
I will visit you.
Good. So anyway, wonderful surgery. I think lots to learn from you. There was one question from Thanasis Nikolakopoulos in the chat box. He's asking you, how will you treat a iatrogenic break?
With laser.
Okay, so Thanasis, I hope you got the answer. So I think I remember Jonovich teaching.
I mean, I don't know.
I'm sure Gianpaolo and our great friend, what's his name? Our Forlini, Cesare Forlini used to learn from Jonovich, because I think in '95, Dr. Di Juan published 19% iatrogenic breaks in managing diabetic retinopathy. And we are 25 years later. And I think we should probably, I don't know what is the percentage allowed, but Jonovich said you should aim at 0. And I think if 0 is a very, very difficult situation, but I think I remember doing a live surgery in Mexico, and I had a terrible retina diabetic TRD. I said, touch wood, I didn't create iatrogenic break, but I think it's the question of patience and assessing the membrane. And sometimes the membrane is thick and the retina is weak. So when you do the bimanual, it's really great. And whatever technique you do, I think you should have aware iatrogenic break is possible. So my answer to Thanasis or to the people who are watching is not try. I always say you cannot try to eat. You eat or don't eat. So same thing here. You either make iatrogenic break or don't make. So best is don't make. So I think you have to prepare yourself like the war. The day before, have a game plan, which Steve Charles mentions, that keep the instruments ready, keep the diathermy ready, whatever you want, and be prepared for a complication. And when you have a contingency plan, iatrogenic breaks don't happen. I don't know whether Marco and Giampolo.
I mean, you try to avoid them. I mean, there are some cases which are so complicated. You do not. It's basically almost impossible that you don't make a iatrogenic break. I mean, it can happen, and when you do, you just manage it. You know, I mean, if we do, all of us do a lot of them. You know that the iatrogenic break can happen, and when they happen, you have to deal with them. I mean,
Right.
that's not a big deal.
Amount of land.
We have constraint of time, so we are adding much behind. So I will start the next presentation so we can discuss at the end. So because few speakers have to leave, so they can present and they can join their workforce. So our next presentation is from Professor Natarajan Sundaram. And yes, please start.
Thank you. I will share the screen. Thank you, Pakan, for this opportunity, and thanks to the EVRS, my good friend, Dr. Giampolo Ghini, for the last visit I had in London with him. So thanks for giving me the opportunity to talk on managing advanced diabetic eye disease. So the burden is 77.7 million we have in India. So we are actually starting the screening. So my idea is to prevent diabetic epidemic, which is happening in India. And because of the eye symptoms, people do not know. So I'm making a program using various things to educate the public. I'm just running through just to say the various stages of vitrectomy. So I'll be, all of us, we know. So I'll go to directly to my video, which is, which will talk, because with all the treatment available, still I remember we have Dr. Peter Hamilton in '88 came to Bombay. At that time it was Bombay, and he said, I will do pan-retinal laser photocoagulation like this and prevent vitrectomy. But it's never going to happen, because in spite of all the control, in spite of all the screening, with all the treatment, with all the injections, what we saw, and then we may have to do vitrectomy in 10% of the eyes. And then that's what I'm going to talk. Here it's a 48-year-old a male with a sudden diminution of vision in both eyes. He's a diabetic since 11 years on insulin. His vision was counting finger, both eyes. And on examination, he had vitreous hemorrhage with diabetic traction retinal detachment in both eyes. And we did both eyes with 1 week apart. And here you see the vitrectomy being done with a 23 gauge vitrectomy. And in spite of all the awareness being done in India, we keep seeing bilateral advanced vitreoretinal problems because of proliferative diabetic retinopathy. And these patients have never undergone laser. And in spite of one group of patients in the cities get everything done, and there are so many diabetics who come year after year with no retinopathy coming. And here you see dense fibrovascular proliferation. Our aim is to release all the anteroposterior traction, then the transaxial traction, and now finally I'm cutting the and diathyromasing before cutting, because as I mentioned that in spite of all that, you can see it bleeds. So that's a problem, in spite of sometimes a burnt out retinopathy, but it can still bleed. So one is to not to increase the intraocular pressure longer than more than a minute, because the risk of optic disc, sometimes the optic disc can become pale post vitrectomy, and we have seen a lot. And also while peeling, sometimes I see sometimes they remove the end block the fibrovascular proliferation from optic disc. I avoid in this patient, I trim the trunk of the thing, which I left the last part there. I didn't want to remove it full, because sometimes that can be the source of, again, neovascularization happening, even though you remove the scaffolding. So whatever minimal traction was there was relieved. I use this brush, again, great innovation of Dr. Raja Jovanovic, my second mentor, whom I spent a lot of time in 80s and early 90s before he retired. And then thank to him, and then we did a pan-retinal photocoagulation. The patient improved 6/18 after 6 weeks, and because of some traction on the macula, which was there for some time, and in spite of that, I think the vision did not improve to 6 weeks, but I think the patient was happy. I always leave the eye with the air or a non-expansive SF6. Many times they ask, why do you want to do that? The idea was sometimes there can be ooze which can happen, and that can be a chance for recurrent hemorrhage. I used to do OPD fluid air exchange earlier for recurrent vitreous hemorrhages. Now because of the anti-VEGF, and then good pan-retinal photocoagulation, as you see here, and then do a fluid air exchange with some gas. The eye remains well for long. And then this is again another patient with a traction retinal detachment. And you can see this is a pre-op fundus photograph with a severe traction on the macula. And then this is the vitrectomy being done for the same patient. And we do a 23 gauge pars plana vitrectomy, and we complete the anterior posterior traction release, and then tangential traction, and clear all the preretinal hemorrhage. And most of the time I use the high suction with the cutter, and this I actually, you can see, I go to the convex side of the traction and use the cutter with a high cutting rate and a low suction. And then I remove I try to do something like an end block dissection, but it's exactly not end block. And I also use this, I'm using the proportional mode, where I'm pushing the fluid between the retina and the fibrous tissue. That means I'm creating a cleavage between the membrane and the retina. And then, so slowly I keep and make a convex surface and go on the upper part of the fibrous tissue, as you see here, and trim off the fibrovascular proliferation. And this is what I'm doing, and which I keep releasing the traction. And you have to be careful. And if you see that, you can see the adhesion between the disc region and the periphery, and that's why the wide angle is very important. And nowadays I use 3D, where everybody can see what you're doing. The idea is to make sure that if traction is happening, and then if you are not careful, at the edge of the traction, it can produce a retinal break. And as Marco mentioned, breaks can happen. And if it happens, identify it, treat it. But my aim nowadays is to reduce the number of, you can see I'm using the proportional mode of the vitrectomy machine to push the fluid and finally release. And in spite of that, of diathermy, alternate diathermy, suction, you have a pre-retinal hemorrhage happening, and I'm here removing the pre-retinal hemorrhage, underlay air, and then do a fluid air exchange. And then in these sort of eyes, I also do a air oil exchange. And then this is the same patient. After, you can see the pale disc, the entire membrane is cleared, the hemorrhage is cleared, there's no oil now. And then the vision was, best corrected visual acuity was 6.9. And this is a 49-year-old female with a history of diabetes for 20 years. We have done a 25 gauge vitrectomy, but in the beginning, I don't do cataract, even though I think I've stopped doing almost, how many years? 36 years back, 37 years now. I don't do cataract. I make my colleagues do, so that I can do something else, either come and do a webinar and go back. And my colleague does I have 3 cataract surgeons. So I think this is done by Dr. Kavita Rao. She's does the cataract. And then I always tell them, put the lens, and then you get out. Then I get in with the 3 ports and then do the vitreoretinal surgery. And many times they want to put one suture. I said, no problem. Go ahead by putting one suture and go. And then I'll, in case required, I'll remove the suture at the conclusion, or I leave it and the cataract surgeon adjusts it post-operative period, maybe a month's time, and then does it. You can see there's no glow. And I always tell them, go ahead and do whatever way you want. If you dislocate the lens, I'm there. I'll go ahead and remove everything, and then you come back and put the intraocular lens. But here, this patient, we have the intraocular lens, and then we proceed with the 3-port pars plana vitrectomy. We are now actually diathermizing the fibrous tissue, which is usually it bleeds. That's the reason I diathermize, and then I'm just again trimming. As you see here, it's a thick fibrous tissue. There's some ooze in spite of extensive diathermy, and now I'm using the perfluorocarbon liquid as a third hand, and using the forceps to grasp and see whether I can release all the traction between it's a combined traction Rigmatogenist retinal detachment. So I'm clearing the fibrovascular proliferation from the break to the optic disc, and then the perfluorocarbon liquid is keeping the macula in position, and partly the break is kept. And you have to be careful, but if you don't release the traction, the PFCL will go into the subretinal space. And and at present, I'm doing a fluid air exchange, keeping the PFCL over the macula and disc. And I'm doing an endodrainage through the break, and I have diathermized the edge of the break, and then I'm now removing the subretinal fluid so that retina is attached, and then finally remove the PFCL. And I have to see whether I've used oil. I don't remember right now. I'll see the end of the surgery. And at present, you see the entire PFCL is also removed. And then I make sure it's totally dry, and then do a endo laser, and then also finally remove the fluid from the center of the eye. And usually after completing laser, that means that it may take there 4-5 minutes, and in the time fluid may get accumulated. The idea is to keep it dry, and so that you know that even if you remove the air, I think the retina will not, and I'm completing the pan-retinal photocoagulation. And this is a problem with many eyes in India, where they never have their eyes checked, and they don't do a regular laser with a proliferative diabetic retinopathy, and that directly come with the vitreous hemorrhage, traction detachment, and combined Rigmatogenist traction detachment. And as you see here, I'm doing the final after clearing. I'm clearing the last part of the fluid direction. It looks like I'm leaving the eye with the air, and then replace it with a 10% C3F8, so that usually these sort of eyes may not need oil because they've removed all the traction and the retina is fine. And I think I'm leaving the eye pseudo-phakic with a C3F8. So, and this is an, so the favorable preoperative, I think all of us know. I'm just, for the favor of time, I'm skipping it. An unfavorable factor, macular detachment, combined retinal detachment, and that's what chronic macular detachment. So I made a program called Screening through Teleophthalmology to prevent diabetic blindness. So the idea is to screen every diabetic and then make sure, and this is my grandfather and father who were ophthalmologists. We all were trained in the same hospital, which is, this is a patient who came bilateral blind, and finally there are two sons. He comes alone and goes. He had oil, and I removed the oil. We have a celebration called Celebrate Vision. So, and I follow this, and Gianpaolo Ghini knows him because he said he's heard about Swami Vivekananda from his childhood. And he says, they alone live who live for others, rest are equal and detached. And I didn't realize, even though I worked in chapel in my school, he said Jesus also said the same. And there's no religion. And this is the school this is the ophthalmology school I studied. My father, my grandfather, my mentor, and even the great Dr. Venkateswamy, who started a government hospital. This is the oldest museum in the world. That's why I wanted to show. And then came many other later in Ghent, and even Moorfield has a small museum. And this is the exclusive building which is there in Madras. I hope everybody can come. Thank you very much. We have 200.
Thank you, Professor Natarajan.
Thank you.
Thank you, Professor Natarajan. We will take the question at the end of our presentations. So we have less time, so we proceed for the next presentation. And our next presenter is Professor Hani Hamza, and he is going to present surgical pulse for safe dissection. Professor Hani Hamza, please. Professor Hani, switch on your microphone.
Okay, I'm going to share my screen now. Just a moment.
Yes, please.
Desktop. I don't know what's share open system preferences. I don't know what's wrong, but I should share
you
it
should
immediately.
go to the green
Can you see my
button
screen now?
No.
It says open system preferences. Okay. Okay, I grant access now.
Screen share.
Later. Okay. We'll share now. Okay, you have it now?
No.
No.
Can you see my screen now?
No.
No, honey.
I'm sorry. Can we move to the next talk and until I solve this?
Okay.
Dr. Jorge? Yes.
So,
Jorge,
dear George, are you
yeah.
ready for next for presentation?
Yeah, I think so.
Yes, please share the slide and start. And George is going to present new concept in diabetic TRD. George, please share the screen and start, please.
Can you see my slide? Can you see?
It's
I can
home.
see your screen, George, but we are still waiting for your, we are seeing your screen.
Yes, yes, share your presentation, please.
We are not seeing the presentation still, but we are seeing the screen.
Okay. Now you can see my presentation?
Yes.
Yes.
Okay. Then I'll go ahead. Okay.
Yes,
thank
go
you.
ahead, Annie. Thank you.
Okay. Thank you. Sorry for this delay. Well, I'm going to discuss today, first of all, thank you, Dr. Hakan and Gianpaolo for this kind invitation. And today I'm going to focus on surgical pearls for safe dissection. And I'm going to be very specific in this discussion. The dissection pearls I'm going to discuss are, first of all, getting into the proper plane of dissection, which is a very important step at the beginning of surgery. How we should divide and conquer, as we do in cataract surgery. We do not deal with large areas of fibrovascular tissue at one time due to cross-traction. We separate the central proliferation from the peripheral ones to minimize iatrogenic breaks. And one important tip is to test the strength of adhesion of fibrovascular proliferation before dissection. Some of them may be more easy to remove than we anticipate. Again, I'm going to show you the multifunction use of scissors, as Marco has shown, whether a closed scissor as a spatula or blunt dissector, open scissor using one blade as a sharp dissector, or both blades as cutting scissors. And finally, changing the angle of attack. These are the surgical scenarios. This is a case of dense vitreous hemorrhage. After removal of the hemorrhage, you will see this large area of fibrovascular proliferation extending across the arcades and the optic disc. The first step is to divide this fibrovascular proliferation into multiple smaller proliferations so that when you exert traction at one point, you do not exert cross-traction and create iatrogenic breaks. So in this case, I divided the proliferation into 3 separate segments, and then I started the bimanual dissection, which was quite easy in this case. Being in the proper plane of dissection allows your dissection to proceed smoothly and without any problems. So after removal of this, you do have some retinal memory, as you can see, and do not try to unfold them. I have one iatrogenic break at this section, and any break should be dealt with by releasing any residual traction and doing endolaser. Here is to show you how testing the attachment may prove as a good surprise during surgery. What looked to be an adherent fibrovascular proliferation actually could be removed simply by suction and smooth dissection using the cutter only until I could release it completely. So initial testing could give you an idea about the difficulty of this case and how you can proceed without the need for bimanual dissection or any more complicated procedures. This is a more complicated case with a broad fibrovascular sheet and multiple attachments. Here, getting into the proper plane from the beginning is actually very important. And this allows you to proceed smoothly with your dissection. It is very difficult in cases with broad fibrovascular adhesions to get into this proper plane, and you have to be very cautious during dissection. After segmenting and removing these fibrovascular proliferations, at one point I have this broad adhesion that I could not remove unimanually, as we have mentioned, so I proceeded to bimanual dissection and removed it at the end. And this is a residual hyaloid over the macula that you have to look for and remove in every case. Another case in which you have to look carefully for the anatomy before dissection, separating the central from the peripheral adhesions. We have the main adhesion at the arcades, at the upper and lower arcades. And as you're going to see, in between, there is a very loose adhesion that you can remove very easily using the cutter and the forceps only. And once you get to the lower arcade, you again have a firm adhesion, and you can remove it using bimanual dissection again at the lower arcade. So testing the adhesion and studying the anatomy at the beginning of surgery is actually very useful and very important, and allows you to do a safe dissection. Another case with a flat, totally adherent fibrovascular proliferation. And here getting into the proper plane from the start is vital, so that you can proceed smoothly with the section. And you can see here how we use the scissor Again, now as a spatula, closed, cutting the very fine epicenters. And whenever I encounter a stronger epicenter, I use the scissor by opening the blades actually as a scissor, as a cutting instrument. And again, as a blunt spatula, proceeding with dissection until it is removed completely, leaving the retina clean. Again, this is a case for which showed how the scissors are used in a multi-purpose fashion as a spatula. And by getting into this proper plane of dissection, you can proceed very smoothly. Whenever you encounter stronger epicenter, just open the blades and cut it. In this upper part of the proliferation, this section was easier, but in this lower part, it was a broader adhesion, and I had to proceed again from multiple angles, attacking this fibrovascular proliferation until it is removed completely from the surface of the retina. Now, moving to combined traction Rigmatogenist detachment. The difficulties added are an underlying mobile retina. Getting into and maintaining the correct surgical plane is much more difficult. Bimanual technique is needed more often. You are more liable to induce breaks during dissection because of the variable plane of the retina being detached. And one surgical tip, do not attempt to drain the viscid subretinal fluid early in surgery. This is a case of combined traction, Rigmatogenist retinal detachment. I started with bimanual dissection. You can see how the retina is elevated, and it is not a uniform plane of dissection. And once you release the traction, the retina can fall back in place. If you try to remove the viscid subretinal fluid through the retinal break early in surgery, this fluid actually stabilizes the retina in place, and it will be replaced by saline, and the retina will become much more mobile and much more bullous, and will make your task difficult. This is the break that was originally causing the Rigmatogenist component of the detachment. I did not try to remove the subretinal fluid, and this is a more dense area of adhesion, just temporal to the macula. Another case, again, I started with the cutter. I found that the viscid subretinal fluid was coming up. So I stopped and decided to go and attack this proliferation using the scissor and forceps. Removing it while the viscid subretinal fluid is still in place allows you to have a more stable retina in the posterior pole, of course, a relatively more stable retina in the posterior pole, instead of having saline or BSS in the subretinal space that will make it more bullous. Now, this is a situation we commonly face. You have broad fibrovascular adhesions, and I find that proliferations at the 12 o'clock meridian, especially when extending to the equator, are much more difficult to dissect because of simply of the angle of attack. You can see I could easily dissect the lower proliferations. When it comes to the upper one, I decided to change my seat and sit on the temporal side and use the 6 o'clock sclerotomy, which was for the chandelier, actually for the cutter, and the scissor for the upper temporal one. Now I have a more comfortable angle of attack, and I can deal with the upper retina like I was dealing with the lower retina. And I can dissect the retina much more in a much more comfortable way until I can achieve complete relief of traction. I did have some iatrogenic breaks, and any iatrogenic break should be dealt with by release of traction. You don't leave any residual traction on it, and you do the endolaser as shown by my colleagues. Now injecting perfluorocarbon, and the rest is the same. But changing your seat or changing the angle of attack to deal with upper proliferations that you cannot reach because of mechanical obstacles by tilting your hands to reach the 12 o'clock meridian is a good idea, actually. To conclude, surgery for PDR is one of the most challenging surgeries for any surgeon. You have to plan your surgery properly pre and intraoperatively, and no case is similar to another. You have to work like a tailor. Thank you very much.
Thank you so much, Annie. Shall we carry on then, please, with Jorge? Jorge, are you ready? and then we'll have the discussion at the end. All right.
Presentation, and we will discuss at the end. A very nice presentation, Professor Hani. Thank you.
Thank you.
And now I invite George Roca for his presentation, New Concept in Diabetic TRD. George Roca, please.
Hi, everyone. Can you see my slide, please?
Yes, yes, we can see.
I'd like to thank my friends, Gianpaolo, Hussein, for inviting me for such a great team of specialists for today, and try to say some words after so many great talks, and I try to bring some new concepts. I have no disclosures. Brazil has so many diabetic cases, have more than 20 million diabetics. It's not like India with more than 70 million, but we have a lot of fractional and retinal detachment. And Robert Macular was the father of modern vitrectomy, and he started with vitreous hemorrhage in 1971. And those days, the result was not so good, and we are waiting more than 1 year to start doing vitrectomy. And nowadays, we spend not only for vitreous hemorrhage, but have spend our indications for vitrectomy, for fractional and fractional combining, and all the bad case, we can improve a lot vision. And diabetic fractional retinal detachment, we can talk about anti-VEGF, combined cataract, small gauge approach, and also OCT intraoperative. And anti-VEGF helps a lot for many reasons. We have less intraoperative bleeding, less use for endodiathermy, short duration of surgery, less iatrogenic break, and we use less oil. And Pacoris was one of the group that's published a good trial. They said that we need to inject for less than 3 days to have less problem with vitreous traction. But recently, we have this publication that's shown us that if you do half dose for bevacizumab, that's use 0.6 to 5 milligram or 0.25 milligram, are the same result for help us with bleeding, but have no traction from the fibrovascular tissue. Another point is to talk about combined surgery, and they help us to be only one trip to OR, the fast improve vision, and it help a lot to better view of the vitreous base, and we can treat well the vitreous base. And nowadays we have very good results. We have here a trial that's shown us that we have no complications if you do combined procedures. And nowadays, all the patients that has more than 50 years old, I try to do combined surgery that I feel much better with my view and feel much better with the post-operative results. And vitreous hemorrhage, the old days, we are used to wait long time. And the first trial that's helped us a lot was early vitrectomy for diabetic retinopathy, was published something like 30 years ago. And they've shown us that the results, especially in type 1 diabetes, it's much better when you do early vitrectomy. And early vitrectomy nowadays do the best for the patients. And why this? Because we improve a lot our tools. We have the better 3D system, we have chandelier light, we have small gauge, we have better vitrectomy machines that can improve a lot. And at the old days, in the early vitrectomy study, we have something like 20% of patients with NLP after 4 years. And this new trial that was in UK, we have barely less than 5% NLP after 5 years. And we are discussing a lot about doing internal limitant membrane peeling. That is a procedure that you're doing when you have macular traction or residual hyaloid, or sometimes macular edema. I can tell you that in a very bad case, I don't peeling at first. I doing this in the second time. I'm very afraid to do peeling. But when the case is not so bad and have some any of these options that I said, I used to peel at once. And as everyone shown us, the tabletop TRD is very challenging. And here, one case that's I just want to. Oh, sorry, the video. And then I just start with Vitrectomy 360 cutting of the hyaloids. And nowadays, I don't use more triosylon to stain the vitreous because sometimes the triosylon go inside or underneath the retina and make more difficult to find a good place to start the dissections. And the other thing that I use viscoelastic dissection, and I stain the viscoelastic that allows me to see the room between the retina and the fibrovascular tissue. And I use all the tools that I have when I have a bad case like this. I use more the Vitrectomy Pro. I like more 23 for this case, but I used to use the Bimanual or use sometime a pick to help me to dissect too, and try to do less iatrogenic break. But as everyone said, it's pretty much rare to do any break. And sometimes I use forceps and to allow me to dissect. And when I have a iatrogenic break, I make sure to clean all the tractions and surround the break. And sometimes I leave some island of vitreous fibrovascular tissue, and these things doesn't change my results at the end. And for the end, I try to avoid oil, but in this bad case with retinal breaks, I use oil, but I try to use more air or just gas. That's good. And if I don't have any break, I don't move the fluid. I just inject again anti-VEGF at the end of the case and try to do laser in the post-operative period. And just for hemorrhage, nowadays with the good machines, I try to do more high pressure. I use 6 milligram for less than 1 minute. That helps a lot. I use compression with the tip of the vitrector. Sometimes when you have bleeding on the optic nerve, I just use perfluorocarbon liquid. That's helped me. Laser is a good tool for some small bleeding. And I do use the endodiatomy, but I try to avoid. They destroy a lot of tissue. There's a lot of trauma. And just at the end, I don't have yet intraoperative OCT, but seems to me that's a good machine. This trial discovery study, they just shown us the feasibility to use and how good information you can have with this new tool. They can identify the good planes, all the traction, and especially when you go for the vitrectomy and they have vitreal hemorrhage that prevents you to use OCT in the preoperative study. These things, I think, in the near future, going to be very popular. And this is the case from this discovery study. And that's for conclusion. I just said that anti-VEGF prepared is a very good tool. I don't use more in all the case. I just choose more. In the old time, I use a lot, but nowadays, I just try to select my case. I use for less than 3 days, half dose, sometimes with only 24 hours before the surgery. Combined phaco vitrectomy, I do a lot if the patient has more than 50 years old. Early vitrectomy in almost all cases. I don't wait more for vitreal hemorrhage to resolve for themselves. New technology, I have to embrace all them. Remove all the posterior hyaloid is the most important. Sometimes in the second time when I remove oil, I can realize that has some hyaloid tissue. I can dissect again. The most important thing we have to clean all the hyaloid and the vitreous base. Avoid as much you can the endotethermy or retinotomy. And I think in the near future, intraoperative OCT is gonna be a good tool for everyone. I just want to show you my beautiful city. One day, I hope everyone can come here and share this view with me. Thank you very much, my friends.
Thank you. Thank you so much, Jorge. We have a question from the audience.
Yes,
I
Ginny,
can't hear you.
We have few questions from the audience. I have collected them, so I will ask one by one. We have
I can't hear anyone. I don't know why.
So, okay, the first question is to Marco Mora. How do you assess visual potential preoperatively in patients who has advanced PDR with TRD? My question is clear?
Yeah, it's very clear. I mean, that's a very difficult situation, you know, because most of the time you have vitreous bleeding. I mean, we just do a visual acuity assessment, see if the patient perceives light or less. We don't do often instrumental examination, you know, especially when there is bleeding. If there is no bleeding and you can see, you can use a potential acuity meter or a laser interferometry, but they don't give much information, to be honest. So I think when there is a TRD, we go ahead and we treat the patient and we inform them about the prognosis, which is uncertain, but if there is a detachment, it needs to be addressed.
Okay, thank you, Mora. So we have second question to Professor Hani Hamza.
Yes.
How do you assess optic nerve status in patient with TRD? Whether it's healthy or not?
That is very difficult. I mean, you cannot even resort to VEP or something like that in the presence of a TRD because it's going to be bad anyway. So as Marco just said, I rely on clinical examination. And if there is a vision of perception of light, reasonable perception of light that I am confident on, I would go on for surgery. It is very important also to point to the patient that if the retina reattaches, vision can improve up to 6 months. So it's not an immediate process. It's going to be a slow process. And usually many of them improve.
So got your answer. So my next question is to George Roca. So how many times in a patient of 45 years old do you prefer to sacrifice the lens, crystalline lens, or you don't prefer it?
If I have a very clear lens, I just don't do the cataract, but you have any kind of opacity, I do for phaco. I think the best thing to do, because sometimes with during the surgery, if the surgery takes too much time, sometimes it's gonna be more hazy and make your time very difficult.
So answer is that if the lens is completely clear, we don't sacrifice the lens. But if there is a minimum opacity, then we have to go for a cataract extraction if patient is 40 years above. So that's fine. So our next, yes, Natarajan, I just take your question.
No. Can I comment on this point?
Yes, so, please.
No, even if there's a little cataract and it's 40 and above, if I'm able to see well, I actually keep it. Keep the cataract. Maybe it'll progress, but I do a vitrectomy and do everything if required, even oil. And I combine a cataract IOL with the oil removal, and then preoperatively do the A scan for both eyes so that you have the IOL power ready, and do the cataract maybe 3-4 months later. Okay. And that's my.
Armin, I have a question for you. So what is your preferred endotamponade choice if you are going to give the endotamponade? Either it's a gas or it's oil. in diabetic TRD with
It's
iatrogenic brake?
any possible gas and oil, only because very often, as you could see in all the videos, we do have in some parts cortex remnants left on the. It's very difficult in diabetic patients with attractive TRD to separate it all. So with silicon oil, they become more fibrotic and you have proliferations. I try to avoid silicon oil whenever it's possible.
So your preference is gas?
It's air, actually, if it's possible. You look at
okay. So,
but it gives you a good view. You don't need no gas if you don't have if you don't have no brake.
If you have brakes, then what's your preferred endotamponade?
Depending on the brake, still trying to avoid silicon oil if it's any possible, and I relieve every traction. I take SF6 at a 15%.
Okay, thank you. So my question is, Professor Ashraf Sharawi. So how many days before, if the vessel's fibrovascular proliferation is very juicy and it's very vascular, more component is vascular, how many days before you will prefer to give intravitreal anti-VEGF in the patient of fractional retinal detachment? Switch on your microphone.
Well, yes. It's around 24 hours to 5 days maximum before the surgery, so that you get resolution of the vascular engorgement, and at the same time you don't get excessive traction or excessive adhesions, which may be difficult during the dissection of the membranes.
That's good.
So 2 to 5 days is the range in which I work.
Okay, so my last question that I got from audience, what is the preferred gauge of vitrectomy for fractional retinal detachment? I think it cannot be consensus, but what's the preferred gauge nowadays?
23 for me.
23, and for Ginny?
Yes.
23. 23.
And for George?
23.
Armin?
23.
And Marco?
23.
I think it depends on the case. In the complex case, PRRD, for sure 23. Easy case with focal attachments, 27. You know, I mean, depends what you have.
Honey?
It's a 23 gauge for me.
Ashraf?
23 gauge for me. Ashraf? 23 most of the time. Just in very selected few cases, 27 gauge.
Okay, Professor Natarajan, what's your preferred gauge for fractional retinal detachment? He's busy somewhere else, I think. So I think we have 2 minutes left. Professor Gini, can you conclude the session?
There are so many more things that could be said. Maybe we shall have another webinar in the future to address more questions, because I think this is a topic of great interest to everyone, and the number of questions and the number of participants just show that. I just want to thank everyone so much for their participation. I want to thank you, Hussein, for having set this up, and all the panelists for their time and their expertise, and obviously to the participants who have stayed with us for these 2 hours and followed our webinar. Thank you very much. I hope to see you in person soon. Thank you.
Thank you, everyone. Thank you, George, Ginny, Henny,
Thank you so much.
Thank you.
Natarajan.
Take care.
Thank you so much. We will
Thank
meet
you,
soon
everyone.
in person.
Thank you.
Good to
Bye.
see everyone.
In a beautiful world. Thank you. Bye.
Bye.
Take care. Have a nice day.
Thank you.